Hello, everybody. I'll be talking to you about how we use medications as part of dementia care. Here's an overview of my presentation. I will begin by a few principles that I want to make sure you appreciate. Then we'll talk about three areas in relationship to medication use. One relates to minimizing medication load, especially medications that might be used for comorbid conditions like high blood pressure or cholesterol. I'll then briefly touch upon medications that are marketed in the US and other parts of the world for cognitive symptoms, such as memory loss. And finally, I will be talking about the use of medications for some of the neuropsychiatric, also known as behavioral symptoms associated with dementia. For example, depression, delusions, sleep disorders, and so forth. Here then are the principles. Perhaps the most important principle is that it is best to use medications sparingly in people with dementia. That is because their brains are vulnerable and they have difficulty tolerating medications. Medication effects can be additive. So 2 medications or 3 medications or 4 medications produce an increasing burden on the brain, and at some point it might be too much for it to handle. The second major principle is that medications should be used for clear reasons. If there's not a clear reason with a clear benefit greatly outweighing risk, medications should probably not be used. I'll talk a bit more about that in the later parts. Also, medication monitoring should be happening regularly. Medication benefits must be monitored, always asking the question, are these medications producing the benefit that is desired? Next important principle is to carefully look for side effects. And keep in mind that side effects might not be typical. In other words, the side effects listed in the books might not be the ones that we see in someone with dementia. A common example is that a side effect where a person might be having nausea might be weight loss. And so weight loss, which can also be due to dementia itself, should often be associated or considered to be the result of a medicine. Finally, there should be the intent and plan to stop medications that do not have a clear benefit. If a medicine is not clearly helping someone with dementia, it should be stopped. There are very few instances where a medication cannot be stopped with a brief period of observation to make sure that it is producing benefit. Minimizing medication load is a really critical aspect of care of people with dementia. All medications, including over-the-counter medications, must be reviewed regularly. Following the principles I just articulated, they must be reviewed for benefit as well as side effects. Of particular attention are medications that have what is known as an anticholinergic effect. Those of you who are clinicians can look that term up and read more about this. In general, though, medications that produce anticholinergic effects are actually quite common and widely used, and they can really impact the brain by worsening memory and other cognitive symptoms. Common examples of anticholinergic medications are those that might be used for bladder control or incontinence, for pain, especially narcotics, sleep, as well as gastroesophageal reflux disease. It's not to say that these medicines should never be used, but rather it should be appreciated that they are affecting the brain and they are affecting cognition when the risk-benefit is being evaluated. Minimizing medication load ultimately means that the overall number of medications should be reduced if at all possible. Examples might be medications for comorbidities. For example, statins or other medicines used to reduce cholesterol or lipids might not be needed. At certain ages, over age 80 or age 90, there really are diminishing returns, and if they are not needed, they should be stopped. The same is true for medications that might be used to manage blood pressure. In general, as people get older, less intense blood pressure control is needed. The management of blood pressure for 40 or 50-year-olds has a different target as compared to management of blood pressure for an 80 or 90-year-old. As a result, if blood pressure medicines are being added or used to keep blood pressure at a lower than appropriate point, they should be reduced or discontinued. Similarly, medications that are used for unclear indications should be stopped, period. People with dementia are often taking as many as 7 or 8 prescription medications, and many times they're taking a number of over-the-counter medications that can be stopped. Another example of over-the-counter medications that are often used with adverse effects include those that are used to manage sleep. Things like diphenhydramine or other antihistamine medications sold over the counter to help sleep can be harmful for people with dementia. There are alternative approaches to helping improve sleep. The next discussion of medicines concerns the use of medicines for what we call the cognitive symptoms of Alzheimer's disease. These are medicines that have been studied and approved in the United States and other countries for the treatment of memory loss and other cognitive symptoms. It should be appreciated that as a whole, these are not cures for Alzheimer's or another dementia. However, they do have a role to play and should be considered, although not necessarily always prescribed, to treat someone with Alzheimer's disease. There are 2 general groups. One are known as cholinesterase inhibitors. What these medicines do is increase the level of acetylcholine in the brain. Acetylcholine is a chemical that is important to the functioning of memory, and that chemical is lost early in Alzheimer's disease. Cholinesterase inhibitors boost, albeit temporarily, the amounts of acetylcholine in the brain. In the U.S., the 3 marketed medicines go under the trademark names of Aricept, Exelon, or Razodine. They each are pretty equivalent in whether they are likely to help or harm, so that decisions should be made in careful consultation with a physician who's familiar with their use and who's familiar with the patient. It is not clear to me that one of these should be preferred over the others. Generally speaking, choices should be made based on the particular circumstance. Why use these medicines? Well, 10 to 15% produce a modest benefit. And these are patients who come back after starting the medicines and look better by all accounts. Patient thinks that their mentation is better. Families and caregivers agree, and the clinical teams notice that. Since this occurs 10 to 15% of the time and can be substantial improvement, it's a good idea to consider trying these medicines if they can be used safely. Otherwise, though, the benefits of these medicines can be small, so that it's important before starting them to have a detailed conversation about what expectations there are around their use, so that if they are not being helpful, the decision can be made ahead of time to try a trial off them. In other words, to stop them to see if they have been helpful. While side effects from these medicines are in general uncommon, if they occur, they can be significant. More common side effects include stomach upset, nausea, occasionally vomiting, loose bowels, diarrhea. More concerning side effects can be muscle cramps, falls, a slow heart rate, and occasionally fainting spells. There are, in fact, in the literature, some links between use of these medicines and sudden death, although this is probably very, very rare. The other group of medicines, with really only one medicine in the class, are known as NMDA antagonists. What they do is they limit the toxicity of a brain chemical called glutamate. Namenda, as it's marketed in the U.S., or Abixa, as it's marketed in many other parts of the world, is the best example of this medicine. The evidence is quite good that this medicine is not very helpful in mild dementia, so it is primarily indicated in moderate or more severe stages of dementia for people with Alzheimer's disease. The effects here are also small, typically improvements in functioning or perhaps slowing of the progression of functional and cognitive loss. Side effects, again, are uncommon, but they also can be quite substantial and important, such as dizziness or falls or even brief periods of significant agitation. The final group of medications relates to the treatment of neuropsychiatric, also known as behavioral and psychological symptoms of dementia. It's important to reiterate that these are universal. Over time, almost everybody with dementia develops one or more of these symptoms, with the most common ones being conditions like depression, agitation, psychosis, referring really to delusions and hallucinations, as well as sleep problems or apathy. If these arise newly, the first step is to make sure that they are not the result of a comorbid medical problem, like a bladder infection, dehydration, pain, or another fairly common problem like that that could go unnoticed and manifest only because of a new behavioral change. Assuming medical problems are not found to underlie these neuropsychiatric symptoms, it is critical that non-medication treatments be tried first. There is a wide array of such options, and they can be quite effective. It is rare that the situation is emergent enough where there's not enough time to try these non-medication treatments or where use of medication is absolutely critical. As I've been emphasizing all along, it's critical to use these medications very carefully. These almost all have anticholinergic effects that I talked about earlier, and so they should be used when the benefit is likely to be very clear and with careful monitoring. They should also be used with a backup plan. What I mean by that is that they should be used on an outpatient basis cautiously, and if there is uncertainty about whether they are helping, if the behaviors are getting worse, or if there are other safety concerns, the backup plan might consider a higher level of care, such as a chronic or acute hospitalization or more intense home-based care. There are three groups of medicines that are commonly used to treat behavioral symptoms. The first group are the antipsychotics. These come as conventional and what are also referred to as atypical antipsychotics. In 2015, there really is no reason at all to use conventional antipsychotics to treat people with dementia. And that is because they clearly have worse side effects and are either less or equally effective as the atypicals. So that if antipsychotics are considered, then atypicals are the way to go. Antipsychotics such as risperidone or olanzapine or quetiapine, the ones that in the US are commonly used in this setting, do seem to help with certain types of behavioral symptoms, in particular agitation, delusions, and hallucinations. Therefore, they can be used in targeted ways. It's important, though, to remember that they can have fairly catastrophic side effects, including strokes, potentially heart attacks, and they are also associated with a higher risk of death. Because of the latter, in the United States, use of antipsychotics in people with dementia carries what is known a black box warning by the Food and Drug Administration. So the risk-benefit equation has to be very clear. In fact, there are emerging options that are non-antipsychotic medications that we'll talk about in a moment, referring to some antidepressants. On balance, therefore, antipsychotics should be used very uncommonly after other medical problems as causes of behavioral symptoms have been clearly ruled out and after non-medication therapies have been tried first. If it appears that an emergency is present and it's necessary to use these antipsychotics, it's critical to try and discontinue them as soon as possible. It's also probably a good idea, if possible, to always involve a specialist when a behavioral symptom is so severe that any kind of medication use is being considered. Antidepressants, in other words, medicines that have been developed to treat depression and other forms of mood disorders, are in fact a fairly good emerging option. The challenge here is that they have not been very well studied and that in fact there is some evidence they don't work as well for classical presentations of depression like major depression in people with Alzheimer's disease. However, there is some evidence now that one of the marketed SSRI, or selective serotonin reuptake inhibitor antidepressants, the one known as citalopram or its cousin escitalopram, appear to be a pretty good emerging option to treat agitation. In fact, in some quarters, for milder or even more severe forms of agitation, even in the presence of delusions and hallucinations, citalopram or escitalopram might be a reasonably good first-line option. There is evidence that there are previously unknown cardiac effects related to citalopram, so that they should be carefully monitored if used. In general, however, most clinicians agree that if effective, they are more safe or safer than antipsychotics. The other group of medications that I'd like to mention are anticonvulsants. Divalproex, also known as Depakote, or carbamazepine, in the past known as Tegretol, are also medicines that I have seen prescribed in people with dementia. In general, however, they should be avoided. There's pretty good evidence with divalproex in particular that it's harmful and is not likely to help behavioral symptoms. Of course, if either one of these is needed to treat seizures, that's a different story. But for the treatment of behavioral symptoms, in my personal view, anticonvulsants should be avoided. I do want to briefly mention a group of medicines known as benzodiazepines. For example, diazepam or Valium, clonazepam, lorazepam, also known as Klonopin or Ativan, are used not infrequently in the U.S. for agitated people with dementia. Their use is pretty common in nursing homes and other institutions. It's pretty clear, though, that the risks almost always outweigh the benefits. So use of benzodiazepines should be greatly limited or restricted because they are not likely to be helpful and can lead to very serious or catastrophic side effects. In summary, therefore, the treatment of behavioral symptoms in people with dementia should minimally use medications, and if medicines are needed, it is critical as much as possible to involve specialists who are quite familiar with their use in people with dementia. Let me summarize then my key point. Medications are, in fact, a key part of dementia care. If used carefully and if used systematically, they provide great benefits both for patients and caregivers. Used carelessly, however, these medicines, especially if more than one are used, can have catastrophic outcomes, even death. It's therefore very important to carefully monitor risks and benefits of every medication over time for people with dementia. One of my favorite quotes in this setting actually comes from one of my firm beliefs, which is that while we can't cure dementia, we can make a huge difference in the lives of patients and caregivers by simply applying what we already know. Dementia care is a mature set of practices that make great differences and improvements in life quality for people and caregivers in all settings. And so I'm a big advocate of using systematic dementia care as widely as possible. I'd like to thank you for your attention. I'm more than happy to take any questions that you may have. I can be reached at the email that you see on this slide. Thank you very much.